dear viewers, I'm Dr. Rakesh Gupta, President Cypher and former Director Health Services Punjab, and I have with me Professor Dr. Sonu Goyal, Department of Community Medicine, School of Public Health, PGIMER, Chandigarh. We are the anchors of the show. We welcome you all for this very special edition of Cypher Health News channel, coinciding with the National Drug and Alcohol Facts Week. And we feel honored to have with us Padma Bhushan Professor Dr. K. Srinath Reddy for an informal talk.
It's a pleasure to be here with you today.
So let me introduce Padma Bhushan Professor K. Srinath Reddy. Professor K. Srinath Reddy is the President of Public Health Foundation of India, and he's a former professor and head of Department of Cardiology at All India Institute of Medical Sciences, New Delhi, and did his DM, Cardiology from AIIMS itself. He's a MSc in Epidemiology from McMaster University, Hamilton, Canada. He has served as Adjunct Professor of Epidemiology at Harvard from 2014, and he'll be serving till 2023. He's an Honorary Professor of Medicine at University of Sydney, and he's a recipient of many awards, including the highest award, Padma Bhushan, WHO Director General Award for Outstanding Global Leadership in Tobacco Control, Queen Elizabeth Medal, and Luther Teddy Medal for Leadership in Tobacco Control, which is conferred by American Cancer Society.
So Professor Reddy, he is the first Indian to be elected to the National Academy of Medicine, USA. He has been awarded several prestigious international and national doctorates conferred by University of Aberdeen, Scotland, Dr. NTR Medical University, University of from Switzerland, and University of Glasgow, Scotland. He is DLET from Jodhpur National University, India, and Doctor of Science Medicine by University of London, UK in 2014. He was elected as Foreign Associate Member of the National Academy of the Medicine, USA in 2004, and was made a Fellow of the London School of Hygiene and Tropical Medicine in 2009. He is an advisor to the Government of Andhra Pradesh on public health, and he has also served as a physician to two Prime Ministers of India.
So besides it, Dr. Reddy has served as many WHO expert panels and has been the president of World Heart Federation in 2013-14. He has more than 500 scientific publications in international and peer-reviewed Indian journals, and has been an editorial board of several international and national journals. He's widely regarded as a leader of preventive cardiology at national and international level, and he's well known Reddy for his work to promote cardiovascular health, tobacco control, nutrition, and chronic disease prevention.
So, sir, we will like to hear about your early childhood and your parents.
Well, I was born in Madras, what's now called Chennai, where my mother had just graduated as a doctor from the Madras Medical College, and my father was then practicing as a lawyer in the High Court of Madras, which was the undivided state of Madras. What is currently Andhra Pradesh and what is currently Telangana were all part of the undivided Madras state. Hyderabad, of course, and some surrounding districts were part of the Nizam state. But most of Andhra Pradesh and some parts of current Telangana were actually part of the Madras state. And I grew up for a few years there. Then as the states were being reorganized, finally moved at the age of 8 to Hyderabad. And my mother was a professor of obstetrics and gynecology, and my father was a lawyer, but with a strong interest in economics and social sciences and political sciences. And he gravitated to politics there, but essentially not the electoral politics of Lok Sabha, but he was brought in as an independent member in Rajya Sabha, and then later on served as a union minister, initially for company affairs and then for labor for about 10 years. He was a member of parliament for 18 years, but principally remained an intellectual in politics, interested in social equity, and had a strong commitment to what could be called socialist causes.
Excellent, sir. So that means that this is in your blood, sir. So the intellectual thing you have and the interest in medicine, so that is inherent actually. And sir, we'd like to know about your education and journey as a cardiologist in AIMS.
Well, I graduated from Osmania Medical College, Hyderabad as a doctor. In fact, my choosing the medical profession was more my father's influence than my mother's influence, while she was the doctor in the family, because he felt that a doctor can always be useful to society till the end of life. And some of the other interests I had in social sciences and literature and political sciences could be also pursued through self-directed learning. But having a structured professional learning, especially in a profession like medicine, could keep me useful to society till the end of my life. And that influenced my thinking, and I became an MBBS doctor in Hyderabad. But then I was attracted by the All India Institute of Medical Sciences, and while many of my classmates went to the United States of America and some to UK, I decided to stay back in the country because I felt most relevant to the country as a physician, and decided that I will take up medicine and then cardiology. And I graduated as a cardiologist after DM Cardiology in All India Institute of Medical Sciences, joined the faculty there. But since I also had an interest in epidemiology sparked at that time, I went to do my master's later on in McMaster University. But I continued as a cardiologist, initially as a fellow in training, and then as a faculty member from 1981 to 2006. I became head of the Department of Cardiology. But while I was serving as a cardiologist, the opportunity came to head the Public Health Foundation of India. So from being a clinical cardiologist and a research cardiologist, but with a strong interest in public health and particularly tobacco control and other areas, I moved over to the broader domain of public health in terms of the Public Health Foundation of India.
So it's an excellent journey, I must say. And as you have rightly narrated, that how you became a cardiologist from in the initial part. And at that point of time, I remember, because I joined MBBS in 1993 and MD later in 99. Thereafter, I think cardiology and similar disciplines were quite popular at that point of time. But later on, you turned into public health. You changed your stream more into public health. And at that point of time, if I correctly remember, public health is not a very fancied profession at that point of time. So what were the factors that actually influenced your journey from a cardiologist to a public health specialist?
Well, as I said, fortunately, because of my father and his voracious reading habits, even as a school student, I was exposed to a large number of books on social sciences, economics, and I became quite aware of the fact that health, particularly at the population level, is greatly influenced by a number of social determinants of health. And I read even a bit of Rudolf Virchow, the pathologist, statesman who became an anthropologist and founder of social medicine, even when I was in medical college. So some of the social dimensions of health were somewhat apparent to me. But I was also very much fascinated by cardiology, and I was very happy with cardiology. But then I started doing a project for the Indian Council of Medical Research in community control of rheumatic fever and rheumatic heart disease, which linked All India Institute of Medical Sciences, as well as Varanasi and Vellore. And when you start going to the villages, because we had to do it in the schools in Ballabgarh area, and I also had to travel to the other places because I was asked to be the gold standard for standardizing other researchers in the diagnosis of rheumatic fever and rheumatic heart disease, particularly the murmurs and so on. You start seeing how much it is linked to poverty, both in terms of the causation and also the fact that many of these people are unable to really access continuous medical services. They can't get their prothrombin time tested, even if they can manage somehow to get a mechanical valve inserted. They cannot always get their anticoagulant medicines and the valve clots. And you see young women dying in pregnancy because of a clotted valve. So you recognize that even if you're sitting in All India Institute of Medical Sciences and trying to provide the best of care, there are so many social factors that need to be addressed. And particularly the weaknesses of the health system need to be addressed. So that dimension was always there in my mind, even as I was practicing cardiology. But then I also went in for some formal introduction to cardiovascular epidemiology in a 10-day international seminar, which was organized by what was then called the Council of Epidemiology of the International Society and Federation of Cardiology, which is now the World Heart Federation. And in those 10 days, I realized that there is so much of science to epidemiology, which of course is translated also into identifying what are the important interventions for prevention and promotion of health. But the scientific discipline of epidemiology attracted me greatly, and that made me seek greater learning through a structured master's course in epidemiology, but which also introduced me to health economics, social sciences, all in an organized master's program in Canada. But even before I went to Canada, we had already started in All India Institute a tobacco control program called the Health or Tobacco Group. And we started campaigning for tobacco control because I realized that tobacco was a major threat to health, and we were already starting to see young people getting heart attacks because of tobacco, apart from cancer. So some of the foundations of public health advocacy being related to public health research started over there. But I became, I believe, a more competent researcher after getting my formal training in epidemiology in Canada. Though even before that, I was involved in the Intersalt study as the principal Indian investigator, which looked at the relationship of sodium and potassium intake to blood pressure within populations and across populations. So I was part of the group that studied 52 populations across 32 countries to clearly establish how much not only sodium, but sodium-potassium ratio was very clearly linked to varying blood pressure levels within and across populations. So I pursued my clinical cardiology. I was very much a clinical cardiologist in the catheter lab, doing cardiac catheterization and so on. But the social dimensions of disease and health were always in the background. And some of my advocacy work on tobacco control started off in the mid-80s and then continued even as I went to do further studies in coronary heart disease in India, looking at risk factors in Indians in urban and rural areas, comparing them to migrant populations of Indians, and trying to see what the gradients of risk are and what are the determinants of risk that accompany both urbanization and migration. So clinical cardiology went hand in hand with cardiovascular epidemiology. Cardiovascular epidemiology went hand in hand with public health advocacy.
Wonderful, sir. I think really inspiring. And I hope that the audience who are young, budding public health researchers will be inspired to take the public health profession, as it's the way you have told that how from preventive cardiology, from cardiology to preventive cardiology, now to public health, your journey unfolds. So, sir, can you tell more about, like, as a journey of a public health expert, what all areas you had ventured into?
Well, basically, fortunately, what happened was that once you discover that public health covers many domains, and not only in terms of the disciplines that feed into public health knowledge, but also into the very many areas of public health practice and policy, you recognize that you have to deal with, for example, the environment, air pollution, you have to deal with climate change, you have to deal with nutrition, public health nutrition, but then you go upstream and then look at agriculture and food systems. How are they actually providing appropriate and affordable nutrition to the people? And what are the barriers in the food systems, particularly because of the commercial determinants of health, which actually distort nutrition and cause a lot of disease? So you start exploring those elements as well. Then you start looking at health systems organization. And you say, okay, it's all right for me to be practicing fairly good medicine in All India Institute of Medical Sciences, but what's happening in primary care? What's happening in secondary care? Are medicines affordable? Are they easily available? what is happening to the health workforce in the country, what is happening in terms of universal health coverage, why are we not actually getting a health system which is much more equitable? So these are questions that arise when you start thinking beyond the catheter lab or the coronary care unit. And you also recognize at some point in time, with all the fascination for gadgets and technologies, that the ultimate coronary care unit is the community. Right. That is where actually the prevention for heart disease has to start. So then you start working in all of these areas, but then you realize that there is so much of synergy and connectivity between these areas. When you talk about food and agriculture systems and the commercial determinants, you find out that the commercial forces that are pushing tobacco are also following similar strategies. In fact, they set the example for others. And then you start looking at what is the political economy of some of these industries which actually cause the risks to go up, risk behaviors to get promoted. How are they aggressively pushing addictions? So these are the kind of questions that come up, and then you take up advocacy for the cause. But you recognize that you have to build coalitions. When you're talking about food and agriculture systems, you have to talk to the people in the environmental groups. So when you're talking about even, for example, tobacco control, you realize that tobacco has an environmental dimension. So you have to try and start building coalitions so that more and more people with the convergent interests in civil society, as well as in the academia, can join together and mount a common demand with an amplified voice.
So thank you, Dr. Reddy. I think our health system has benefited from your knowledge as an interventionist and as well as a public health specialist. So, sir, since you are considered as one of the senior most tobacco control enthusiasts, what do you think are our achievements in tobacco control in the last decade? And also let us know about your role in FCT's negotiation as India's technical delegate.
Okay, let me first talk about the country's achievements before I become a little immodest and talk about my role. So, but since you have invited me to do that, then I will have to do that too, because it is linked to what the country did. And I was fortunate to be part of that negotiating process. Basically, if I have to look at the various things that have happened over the last decade, let me just look at what the achievements are by way of 85% of pictorial health warnings enforced from the 1st of April, 2016. That's remarkable, very high level of pictorial warnings, despite opposition from several members of parliament who are interested in protecting the tobacco industry. The e-cigarettes have been banned through an ordinance with effect from 18th of September 2019. 35 Indian states and union territories have notified prohibition of gutka and pan masala with nicotine since 2012 to 2020. Then we see tobacco-free film and television rules enforced from 2nd of October 2012. Then we also see that the code of conduct for public officials for Ministry of Health and Family Welfare and autonomous institutions have been enforced thanks to advocacy of people like you. All of you have combined together and have ensured that government officials are not sitting in meetings, public meetings particularly, with tobacco industry officials and appearing to legitimize what the role of the tobacco industry is. So I think that firewalling was necessary. Then we also see that the 3 national tobacco testing laboratories have been established in Noida, Guwahati, and Mumbai. The national tobacco cessation quitlines have been launched in 2016 and with extensive networking of tobacco cessation programs. And we have seen all of these actually having an impact. If you look at the last GATS, the Global Adult Tobacco Survey of 2016-17, a 17% relative reduction in tobacco use has been reported since 2009 to 10, which is the first GATS. And India also ratified the WHO FCTC illicit trade protocol in 2018. So India has been very much in the forefront, except perhaps in the area of taxation, where we could and should do a little better, we have generally occupied a fairly strong position in the forefront of tobacco control action among the low and middle income countries, and in fact, globally, even compared to other countries. And since you asked me about FCTC, that process actually started then, because the FCTC negotiations started in 2000. I was asked by the Ministry of Health to join the delegation as the only technical delegate, others were bureaucrats. There was also somebody from the External Affairs Ministry with legal qualifications who came in for some of the negotiations. We were a very small delegation, usually 3-member delegation from Delhi. And it so happened that I was the only constant feature across all the 6 rounds of negotiations, because others would change. And since India was also asked to be the spokesperson for the entire Southeast Asia region, and towards the end of the negotiations, India was also asked to become the spokesperson for a number of developing country groupings on key articles like advertising, and which was the Article 13, which was the last article to be approved, because there was stiff resistance being posed by a number of countries for any ban, comprehensive ban on advertising, sponsorship, and promotion of tobacco products. And also on cross-border advertising, there was stiff resistance to block it. I was made the chief negotiator on behalf of 90% of the developing countries. And we had to go almost frontally in combat with some of the other countries like United States and Japan and others who were trying to dilute the regulations. And in that, I recall some interesting instances, if I may stray a bit. In that negotiation, finally, the Brazilian chairman of the conference tried to arrange a final negotiation because everything was getting blocked because of that particular article. And he thought he'll find a compromise. And he called about 20-25 countries, including India, and because I was the principal negotiator for the Developing Country Coalition, and said, well, we can put the first clause as comprehensive ban. But the second clause, can we say, notwithstanding the above, countries can have a regulatory regime controlling some things like this, in which he said, basically not a comprehensive ban, but some sort of a mix of few regulations. That is because the United States had said its constitution prevented it from having a comprehensive ban because it negated the so-called First Amendment, the freedom of expression. So we agreed to whatever we said. If there are countries with constitutional barriers, fine, but everybody else must have the comprehensive ban. But then the tobacco industry wanted to get other countries also out of the loop, the countries like Argentina, etc. So they were trying to get an escape clause. We were fighting it. And the chairman said, okay, now, because things are not advancing, I will give a compromise formula. And because English is not my native language, I'll depend upon the English-speaking countries to decide whether this is appropriate or not. And if they say it's appropriate, we'll pass it. So then he said, first one is comprehensive ban, and the second one is notwithstanding the above, countries can adopt a regulation regime. Australia said yes, Canada said yes, UK said yes, USA said yes. Then I put up my card. Then I said, Mr. Chairman, I speak with some trepidation because I'm not from an English-speaking country, but because of an accident of history, we have acquired some proficiency in that language. And if you say notwithstanding, it means in spite of.
Yeah.
May I say, notwithstanding your best efforts, the impasse is not broken. So finally, we won the point. Then they brought in the Australian Trade Commissioner for WTO to say that cross-border advertising cannot be prevented because that is a negation of WTO's right. It is arbitrary and discriminatory, controlling the freedom of trade. Then I said, it only talks about, WTO only talks about restrictions to import. It doesn't talk about any restrictions on exports, that the right to export is not there. Otherwise, if every country had a right to, was compelled to export because of the WTO, every country would have enriched plutonium. So we won both the points. The point, what I'm saying is, we could do this because back home in India, we were also at the time under Mrs. Sushma Swaraj advancing the Indian Tobacco Control Act, the COTPA, which had strong provisions. If India had a weak act, we couldn't have advocated for a strong act at FCTC. Both of us went parallelly, and India got the maximum number of awards for its role in the international treaty negotiations. On the day the negotiating body adopted the treaty, finally, I got an email that night from Dr. Judith Mackay, who is a leader in global tobacco control and who was advisor to the WHO Director General Brundtland. She said, as I went to bed tonight, I said to my husband, thank God for India. So not many people know this, that India really played a major role. And I credit our Indian government because they stood firm on the Indian Act, so we could advocate for a strong international treaty.
And thank you, sir. And for all the tobacco control community, I think they must be thankful for the way you negotiated FCTC. And that is the reason that we did a good job in last decade. And luckily for me and Dr. Sonu, we were all a part of the journey in the last decade. So, Dr. Sonu?
Yes. So, sir, I think just want to ask you, because you have been a clinician, you have been a public health expert. So, which journey was more satisfying for you, as a clinician or as a public health expert? And how do you see yourself? Because you have many such instances where the healthcare improvement was healthcare was benefited by your presence. So, just you have enumerated a few of them. So, can you name some more where health system of the country is benefited by your presence?
Well, I don't want to attribute anything to myself because we are all part of a system and part of teams. But both are satisfying. As a clinician, you are helping an individual, you are giving relief to that individual and the family. And if the person improves because of your care and attention, and you can partner the individual in the journey towards better health, then it gives a tremendous amount of emotional gratification. But as a public health person, you realize that there are many people who are suffering because we are not able to prevent disease or not able to provide the services for disease management in the manner that they desire and deserve. And if you can remove some of those barriers by removing the system defects, then you realize that you're also helping a lot of people, even though the immediate identity of the person is not known to you. The issue with public health is the beneficiaries are faceless and nameless. The anonymity of prevention doesn't always give the same recognition or emotional gratification. But ultimately, when you see clinical medicine is providing health in retail, public health is providing health in wholesale. So both are good. Yeah. And as long as you can combine both of them, it's nice. Now that I'm totally into public health, I feel very happy if things improve, the systems improve. But at the same time, occasionally, though I'm not a practicing cardiologist now, if some old friends or some family who have followed me for a long time ask me for free advice, I still feel happy when I give that advice.
Wonderful, sir. Wonderful. So I think, sir, any example of your presence in the healthcare I know that's a teamwork, but besides tobacco control.
I think the most important element I can personally take some satisfaction in is in the area of universal health coverage. In 2010, late 2010, I was appointed chair of a high-level expert group to prepare a framework for for universal health coverage in India by the Planning Commission of India. And it has a 15-member committee, and I was the chair. And we worked on it and submitted the report by 2012. Some of the recommendations went into the 12th five-year plan, but they were never fully implemented for a variety of reasons, because then the Indian economy started going into a bit of a slump. And then also they had other priorities like the Food Security Act. But fortunately, our continued advocacy and the fact that we had a very well-argued report helped in getting many of those into the National Health Policy of 2017. And then when Professor Vinod Paul he was a member of the committee which I chaired, the high-level expert group. When he became a member of the Niti Aayog, he was fully familiar with the report, of course. And then the health and wellness centers and some of the other elements were brought in. And the framework of universal health coverage has now been established to some extent. It still needs to progress. But the emphasis we lay on primary health care over there, and that has been picked up very strongly. And I think that's a contribution, because what we did as the high-level expert group, going into the national health policy and then subsequently into parts of Ayushman Bharat, I think that has shown a degree of continuity of developing the health system towards universal health coverage. I also co-chaired a committee on air pollution and health for the Government of India, for the Ministry of Health, which helped to bring about some of the elements of the National Action Plan for pollution control. So these are some of the areas where we have been working. And of course, in the area of non-communicable diseases, cardiovascular diseases, and other non-communicable diseases, we have been working together. And I think some of those programs also we have provided inputs. But I think through the Public Health Foundation of India, we are trying to establish capacity for education, research, for health system support, a broadband approach to public health capacity building, which is absolutely important if India has to deliver its promise to the people of providing good health services across the life course.
Right, right.
Thank you, sir. And sir, I would like to ask you, do you think there's a shift in the focus of government funding from curative medicine to preventive medicine over the last 2-3 decades? And another question is, has COVID accelerated or halted the strengthening of the Indian healthcare system?
Well, I think over the last few years, there has been a greater interest in strengthening the primary health care and the public health component of it, but it needs to move further. Because of COVID, I think people have become much more conscious of the fact that we need to invest in health overall, particularly in prevention, but also in strong health systems. Initially, when COVID first hit us, all the preoccupation was with tertiary care hospitals and with ventilators. That was the image that was dominating. But then people realized that firstly, ventilators are required in very few people and they help very few people. But they realized that ultimately you have to first of all diagnose people by symptom surveillance, syndromic surveillance of symptoms, preferably at the household, early detection of cases, early testing, contact tracing. All of these are important elements. I mean, you cannot leave contact tracing only to apps. Epidemiology and public health are both a combination of shoe leather and smartphones. You require feet on the ground. You require people in the health workforce. So that recognition has come in. And even if you have 80% of the people now are being advised home care. Now, unless your primary health services are strong, how are you going to deliver home care? So, and if your district hospitals are weak, and don't even have oxygen supply, how are you going to take care of people who don't need ventilators but who could benefit from oxygen? How are your emergency transport systems? How are your health information systems? So the idea of public health, not merely as, vague idea of prevention that, okay, this is only to deal with water and sanitation, which are important, very important, but it deals with systems. The fact that it actually organizes systems, whether it is for prevention or even for good clinical care services to be delivered, which are not entirely individual transactions, but system dependent, that dimension has come through now. We have to pursue that. The fact that the 15th Finance Commission has asked for much greater investment in primary healthcare, both urban and rural. It has asked for local bodies to be empowered. Our latest budget has also emphasized much more on surveillance systems plus prevention. Now there is attention to One Health, because we realize that this zoonotic diseases migrate from wildlife to veterinary population to human population. A lot more of epidemiology and public health is being understood. Some of it is going into health system strengthening. All of that is good for public health. However, once the pandemic passes, will the same attention remain? Will people go back to the old habits of ribbon cutting of intensive care units rather than doing more for primary health care? That we'll have to wait and see.
Right.
While it's very unfortunate that this pandemic is getting prolonged, at least it is keeping attention focused on health and on public health. So we must make the best advantage of it.
Right, sir. Right, sir. Sir, just want to ask that over a period of last 2 or 3 decades, now there is an IT boom, and the IT sector has been utilized, especially in the health sector, for quite some time, and especially in these COVID times. So how do you feel is the potential of IT sector in improving the healthcare delivery? And also tell us briefly.
Absolutely. I believe the IT can be a great enabler. We ought to use technology to our benefit, because particularly since our health workforce is small in numbers and also needs skill upgradation in some levels, and we need to quickly bridge some of the gaps that exist by using IT as much as possible, both for extending the reach of healthcare as well as the quality of healthcare and the timeliness of reports and data, so that you can take speedy action by way of early rapid response. So there is so much that IT can help us. But the caution is, if people think that IT alone will substitute for improvements in the rest of the health system, that will be a mistake. Because you need people on the ground. Even for telemedicine to function, there has to be somebody at the front lines in order to deliver the services which the specialist is advising and guiding. And secondly, artificial intelligence is very, very good, but it is also context dependent. It depends upon the algorithms will develop based on what the data you are feeding. Right. And if the data are derived entirely from a different population, from a different social and epidemiological context, some of those algorithms may not fit in here, either for diagnosis or treatment. You need a lot of local data to be fed in for getting context relevant algorithms. So I think we must use the IT very intelligently, rather than feeling that it's going to be a substitute for rest of the public health system strengthening effort.
Right, sir. So just this Cypher Health News Bulletin is being released on the occasion of National Drug Alcohol Facts Week. So kindly say something on the importance of this particular day and this particular public health issue.
I think, unfortunately, we are seeing a huge problem related to alcohol and drugs, which is now creating both health problems as well as social and economic problems for our country and globally. And tobacco has been one major evil, but these are again going to be major challenges that we must combat. And this is increasing globally, and many of these are following the same script as the tobacco industry. But we'll have to try and identify how best we can deal with it. I mean, I don't have to recount all the dangers that are caused by alcohol and drugs. We know them, right from cirrhosis of liver to gastrointestinal cancers to accidents and violence, including domestic violence, and particularly road traffic accidents, which kill a large number of people at a younger age. In fact, alcohol-related deaths are much more in the 20 to 39 age group because of these accidents and other violent deaths. And we know that there are a number of other effects even on pregnancy and health, pregnancy outcomes, fetal alcohol syndrome, prematurity. So many issues are there, different parts of the body. And as a cardiologist, I'm only too conscious of the fact that it is a major cause of hypertension, both in terms of precipitating and perpetuating hypertension, a major cause of stroke, and a moderate amount of alcohol can even cause precipitate heart attacks, cardiac arrhythmias. There's so many problems associated with alcohol. I don't even have to go into that whole listing, apart from all the evils it does over the body. But drugs, that's another huge problem, and particularly being located in Punjab, you are seeing what the consequences are of young people being led astray. And that is something extremely sad, because if young people are losing their potential for development and playing a useful role in society, they're not only harming themselves, they're harming their families, they're harming the country. And you're losing an opportunity to live a productive life, a happy life. And I believe it's absolutely important that we must provide all the facts to people so that they don't get trapped into this habit. Because the problem is, particularly young people, when they get even addicted because of simple experimentation, it can become a lifelong addiction. Right. And when I say lifelong addiction, unfortunately, it's not a life that's going to last long, because people will have premature deaths. So we will have to definitely get them away from this habit, and whatever can be done, not only in this week, but year around, is going to be very, very important.
And so in that case, I think tobacco control becomes all the more important, because tobacco, nicotine is a gateway drug to all other addictions.
Absolutely. You're absolutely right. I mean, that is one thing that has been very clearly shown, that it's a gateway drug. And people do get addicted to other more harmful drugs and alcohol, certainly, because they're now dependent on nicotine, and one form of dependence leads to other forms of dependence.
So now we'd like to know about your family and some glimpses about your personal life.
Well, my family may dispute whether I have much of personal life, but that's a different issue. But my wife is a pediatrician. Okay. She trained as a developmental pediatrician, interested in childhood disabilities. But after having worked for some time with the spastics, she started work in the All India Institute of Medical Sciences in the Department of Pediatrics in a research project, then moved to the Spastic Society of Northern India, because when she accompanied me to Canada, she had experience with the developmental pediatrics there. But she wanted to work for people with childhood disabilities, particularly cerebral palsy, work with the Spastic Society of Northern India, and then decided that children from poor families are coming too late in their life for effective rehabilitation. So she's set up a small group which works in the slum areas and low-income communities of East Delhi, trying to help disabled children from poor families with community-based rehabilitation, and also training the mothers and other caregivers on how best to look after persons with disability, and trying to see whether they can get educational opportunities or livelihoods. So essentially, she has moved into a broader development spectrum. My daughter is an environmentalist, and she trained as a lawyer at one of the national law schools, but then decided as a fairly young person that she had to do something to improve the environment. She did a master's in international affairs and environmental policy in Columbia University, worked for a few years in the US, including with Vice President Al Gore's organization, the Climate Reality Project. But then she wanted more ground level work. So she moved to Africa, to South Africa. Last 5 years, she's been working on climate change and water projects across all of sub-Saharan Africa. She's located right now in South Africa. My son trained as an engineer, and after having worked a little bit as an engineer, wanted to do something different. And now he is in the media monitoring group of BBC, looking at Southeast Asia as well as East Asia and Pacific Islands.
Sir, it's truly inspiring to know about your family, right from your father, mother, yourself, your wife, your sons, your daughter. I think it's really a wonderful journey, and I think it's truly an inspiring story. So just any couple of messages which you'd like to give to our young budding clinicians and public health specialists?
Well, I don't want to appear as a very, sagacious person giving a lot of advice, but I would only like to say this. Firstly, keep your horizons fairly broad. You may develop a lot of excellence in the field of your choice, and you must try and pursue excellence. But you must recognize that what you're doing in your field is still related to rest of society. In some way, you must influence the rest of society and let the rest of society influence you in your work to keep that connectedness together. And if you can actually keep that commitment to social good as your prime objective, even if you focus very strongly on your profession, you're still going to be doing a lot of good. But you may be able to help others also to do some good in their lives, which will ultimately help to improve society. That's why I tell our public health students that what we are trying to produce are T-shaped individuals like this. That is, have depth in one area or two areas, whichever you choose over lifetime. That means you must have strong expertise in that area, which builds your credentials. But you also have great awareness and familiarity and connectivity with other disciplines, so that you know who to collaborate with and how to collaborate, and how you can together produce knowledge in a cross-disciplinary manner, because cross-disciplinary knowledge is absolutely important for finding the right solutions to complex problems. Right. Almost everything is a complex system problem now. Right. You may have some solutions which are somewhat focused and siloed, but you'll still have to fit it into the broader context. The spectrum of science is reductionist in content, but holistic in context. Right. So even to be a good scientist, practice your focused area of research, but try and fit it into the broader context.
Right, right. Wonderful. Wonderful.
So it is a wonderful journey, sir. And I'm sure the clinicians, the young clinicians and the public health specialists, they will benefit from your journey. And thanks a lot, sir, for being with us and for this informal talk.
And thanks a lot, sir, again for your really a wonderful, inspiring talk, which will really benefit our youngsters. And rightly said at the end, I think we all should focus on social goods. So that should be one of our aims in the life, besides our professional aim, where we need to be holistic at one end, and at the same point of time, we need to know certain points at depth. Thank you, sir. Thank you. And thank you, viewers, for listening to this wonderful session, wonderful informal talk with Professor Srinath Reddy. Thank you, sir. Namaskar.
Thank you. Thank you. It's a pleasure to be with you today. Thank you.
Welcome to Cypher Health News. I am Dr. Astha Sharma, presenting you the latest health news. First up, mapping the road to patient safety with incremental innovation. According to Dr. Sanjeev Kumar, chairperson of the Indian Academy of Public Health and Indian Alliance of Patients Group, former senior advisor at UNICEF and former director at IIHMR, India has made a substantial progress in health, with life expectancy increasing from 32 in 1947 to close to 70 in 2017. with a decline in many communicable diseases and substantial decline in infant-child mortality rates and maternal mortality ratio. However, many areas of concern remain in healthcare. With the non-communicable diseases on the rise, India is home to an estimated 22.2 million chronic obstructive pulmonary diseases and 35 million chronic asthma patients. The country is known as the diabetes capital of the world, with 11.8% prevalence of the disease in India. India accounts for 27% of the global tuberculosis burden, with a gap of 26% in detection and treatment. Innovation in pharmaceutical medicine often occurs as a series of incremental advances in safety and efficacy by comparison with existing treatment, which results in significant improvement in patient care. Second up, a lifestyle intervention targeting women with obesity and infertility is more effective in increasing the pregnancy rate compared with fertility treatment, a new study suggests. The study presented virtually at ENDO 2021 showed that the lifestyle intervention called the Fit for Fertility program is a cost-effective alternative to the usual standard of care for women with obesity seeking fertility treatment. A study shows that the FFF program can significantly improve the pregnancy rate, especially the spontaneous pregnancy rate when no fertility treatments are required, as well as live birth rate, said lead researcher Matthew Balin from the University of Sherbrooke in Canada. Lifestyle changes and a moderate weight loss of 5% to 10% of a woman's initial weight have been shown to improve the odds of pregnancy in women with obesity and infertility, the researcher said. Third up, according to FIAMA Mental Health Wellbeing Survey India 2020, which covered 15 cities across India with over 700 participants aged 18 to 45 years, 1 in 4 young Indians feel that mental health issue can start as early as the teens, while 70% of the young India feels that one is susceptible to mental health issue by the age of 35, given the socio-economic milieu we live in. It has been found that 77% Indians feel that the current level of conversations and initiatives around mental health in India are insufficient, while almost 9 in 10 know this is an important health aspect. Fourth now is that digital tech adoption in healthcare among highest in India. While 74% of respondents in India reported that digital technologies and data solutions have increased staff productivity, 75% reported that digital solutions have been effective in delivering better outcomes for the patient and service users. Digital technology adoption by Health and Human Services Organization is among the highest in India. It showed a survey by global consultancy major EY and Imperial College London. The findings showed that 51% of the respondents in India have increased their use of digital technologies and data solutions since the outbreak of pandemic. The results are based on a survey of more than 2,000 global HH professionals in 6 countries: India, Australia, Italy, the United Arab Emirates, the UK and the US, including 359 respondents from India. A new study has found that about 35% of Americans with a cancer history had an elevated risk of cardiovascular disease in the next decade, compared with about 23% of those who didn't have cancer. Based on a risk calculator that estimates a person's 10-year chances of developing heart disease or stroke, researchers from the Ohio State University found that the average estimated 10-year risk for a cancer survivor was about 8% compared to 5% for those who didn't have a history of cancer. The new study appears in the journal PLOS 1. We know that obesity, cancer, and cardiovascular diseases share some common risk factors, and in addition to those shared risk factors, cancer patients also receive treatments including radiation and chemotherapy that can affect their cardiovascular health. We call that cardiotoxicity, said lead researcher Xiaochen Zhang, a PhD candidate in Ohio State's College of Public Health. That's all for today. Thank you so much.